Institute. This webinar series features real-world case studies from fellow radiologists that will arm you with an action plan that will allow radiologists to take a leadership role in shaping the future of healthcare. Tonight's session is based on the case study Sizable Solutions, which features Dr. Roger Ng, Chief of Radiology at Chinese Hospital in San Francisco. Dr. Ng is joined by Linda Schumacher, Chief Operating Officer of Chinese Hospital. We are very fortunate tonight to also have Dr. Jeffrey Rubin for our moderator. Dr. Rubin is Professor of Radiology and Bioengineering at Duke University. By participating in tonight's presentation, you will have the opportunity to earn 1 Level 4 mandatory RLI credit. You will receive an email tomorrow with instructions on claiming this credit and an email in a day or two with a link to tonight's recorded session. Before I turn it over to Dr. Rubin to get things started, I want to quickly review 2 housekeeping items. Tonight's presentation is scheduled to last about 45 minutes and will be followed by a 15-minute Q&A. Please feel free to submit your questions at any point during tonight's session by typing them into the questions pane. Your questions will be addressed at the end of the presentation. And finally, if you have any questions now or at any time during the session, or if you're experiencing any technical issues, please feel free to type your questions into the questions pane as well, and someone will assist. Again, thank you so much for your time and interest in this exciting series, and I'd like to now turn it over to Dr. Jeffrey Rubin to get the discussion started. Dr. Rubin, are you there?
Hello, are you now hearing me? Hello?
I can hear you now.
My apologies. Let me start over. I wanted to first welcome everybody to this webinar and to congratulate everybody for taking the step to advance their leadership and to embrace Imaging 3.0 in advancing their practice. It's a great privilege tonight for us to host this particular session with Dr. Ng and Ms. Schumacher on becoming a change leader. We're going to first just have a brief review about Imaging 3.0 so everybody is comfortable with what we're referring to in this initiative. Imaging 3.0 is a vision of where radiology needs to go in the future, and really now is the future. And there's 3 key actions that center around Imaging 3.0, which relate to a change in our culture of how we practice radiology, embracing a portfolio of new IT solutions, and aligning our incentives more effectively with those with whom we work with in the health system outside of radiology. I should mention that these principles are not new, and for many of you on the call, you may be successful in already implementing elements of Imaging 3.0, and to you I say congratulations, and of course there is always more work for us to do. The basic premise of Imaging 3.0 is to move from volume to value. And we're just getting some control here of the slides, as you can see. In a sense, what I want to convey is that we are both seeing a change in transactional approach to a more consultative approach in how we approach what we do. The principle of being a little less radiologist-centered and focusing in a more patient-centered way in how we prioritize the work that we do and in how we engage with our referring physicians and with the patients themselves. The idea of moving from the interpretation being the primary focus of what we're trying to achieve to improving patient outcomes. And in doing this, concerns that radiology would be commoditized migrate toward us really becoming an integral part of the care delivery team. Many people have considered the radiologists to be invisible in the reading room in the past, and within the context of 3.0, we become very much visible and very accountable and step forward as we become a true partner in the healthcare delivery team. And so with that broad background on Imaging 3.0, it's a great privilege for me to turn the podium over to Dr. Eng, who, as you have heard, is the Chief of Radiology at Chinese Hospital in San Francisco, and also is the incoming president of the San Francisco Medical Society, which is a tremendous demonstration of radiology leadership for the medical community as a whole. Dr. Eng, the floor is yours.
Thank you very much, Dr. Rubin, and for that great introduction on Imaging 3.0. Let's move on and talk a little bit about change leadership and change management. If we could have the next slide, please. Change management, a lot of people mix up the two. So an explanation of their differences is in order. In a 2011 Forbes article, Harvard business professor John Cotter made the following distinction between change management and change leadership. Change management is a set of basic tools or structures intended to keep any change effort under control, whereas change leadership is more about big visions. It's making those bigger leaps when windows of opportunities arise. These windows are coming at us faster, but staying open less. So you really need to make a larger leap at a faster speed. Tonight, we'll be talking about how to become an effective change leader, or put it another way, how radiologists can use technology and Imaging 3.0 strategies to make it painful for hospitals to get rid of them. A little bit about my practice. Golden Gate Radiology is a small 5 full and part-time radiologist practice in San Francisco in the heart of Chinatown that mainly staffs Chinese Hospital. Chinese Hospital is the last independent hospital in San Francisco. We perform over 40,000 procedures on patients who are mostly low-income, first-generation Chinese American immigrants. When we first arrived at Chinese Hospital in the early 2000s, we quickly realized our immediate challenges. It was all paper and film-based. Films were regularly lost. Waiting times are in the months for some procedures, and for drop-in studies like chest x-rays, the waiting time was so long we were giving out pagers like you see at Cheesecake Factory and asked them to go shopping for hours down Chinatown or get a roasted duck while they wait. Understandably, the doctors and the hospital staff expected and got poor performance from radiology. So clearly, it was a time for change. We knew early on that implementing risks and packs was our calling card to the rest of the organization. For the radiologists to be perceived as change leaders, we had to focus on the department first and foremost. While the risk pack system did address many of these problems, we learned that the harder, more insidious issue was changing the existing culture of how everyone did things. So in the process of advocating for and building risk packs, we began by engaging all parties, including key specialists and medical staff leadership, to gain their input and support. And now for perspective on the hospital side, I'd like to introduce Linda Schumacher, our CEO of Chinese Hospital.
Thank you, Dr. Eng, and it's a pleasure to be here this evening. It was actually very easy to help implement the RIS-PAC system into Chinese hospital because of a number of operational issues. As Dr. Eng mentioned, we have a lot of efficiency issues within the hospital. But above and beyond that, we actually also are extremely space challenged. And so transition to an electronic-based and digitally saved image really helped reduce our storage requirements, so we didn't have to keep all of the film on site, allowed access throughout the hospital to images by our physicians for their patients who were in the hospital. Also helped us easily provide images for patients who are receiving consultations in other facilities. And then additionally, as we've been are building a new hospital, we've had to sort of decentralize some of our systems, and it allowed us to link these various outpatient centers and sites and have the radiologist function out of a single reading room. So that really has helped us overall to increase some of our efficiency and our overall reduce some of our cost of operations.
Thanks, Linda, for that overview of the operations during that stage of our transformation. So moving on. That's who it was. We always approached the relationship with the aim of addressing their needs. Change leader takes time and effort. At least we haven't found a shortcut for this process yet. Our experience agrees with studies showing change leadership can be developed in all of us. The more face time we have, the less we are a commodity. Ironically, out of all the things we do, our most effective anti-commodity activity was spending time in the doctor's lunchroom, where docs could place the face of our radiologist with the name on the report. Among the numerous committees, we found serving on the hospital medical exec committee or the hospital board of greatest value to understanding our organization's strategic vision and how imaging fits into this future, all the while allowing us a platform to advocate for radiology's vision. Our full-time RADs serve about, on average, 4 committees. In general, the more activities we engage in, the more we have be seen as a resource in other areas. We would recommend that you give your leaders time to get involved at this level, as it takes time to sort of pay your dues and work their way up the ladder to those leadership positions and committees. We encourage everyone in our group to be involved in those activities, not just our president. Or community-wide EMR adoption, rarely has it been a straight line. But because we kept engaging, we expanded our sphere of influence over the years while driving 3.0 value initiatives. I'll give you one example. Our physician-run IPA is comprised of about 200 independent, solo, and small group doctors. The role of the IPA is to contract with the health plans and provide resource support to its doctors. In 2010, they correctly saw the need to create an enterprise EHR, linking up the solo doctor offices and act more like a Kaiser-like integrated system. Given my experience with adopting RIS and PACS, which is our version of EHR, as well as my experience in organized medicine, I was fortunate enough to be chosen as a participant in this conceptual planning and implementation. The need to create this enterprise EHR was for some strategic reasons. One was to have better integration of care among these solo doctors, as I described, but also to achieve meaningful use EHR for those doctors, pay for performance, which is increasingly a impacts the IPA because revenue is being driven by the health plans to be more pay for performance. So it's not just doctors, it's also the organizations that are under that type of change. And then lastly, better integration of care between the doctor offices in the community and a Chinese hospital. So many of the advocates for the EHR saw and cited the radiology department as an example of how to implement its potential benefits. However, many of the implementation team were overly enthusiastic about the vendor's perfect demo, ignoring the pitfalls that we radiologists learned in the early days of PACS in the areas of usability, integration, and portability of data. The IPA unfortunately ignored these warnings, and they're now paying for it with the price of completely shelving the existing EHR and going with a brand new EHR, which is, as you can imagine, very costly. After this expensive learning lesson, they are now following the advice given during the first go-around. So I suppose that the learning lessons, that patient does pay off, and may take a while for your advocacy to take root, though. Meanwhile, the hospital installed its EMR and adopting meaningful use around 2013, and we radiologists have been involved with the implementation and improvement of that EMR system. And now Linda will say a few words about the hospital's perspective and how radiology success with RIS-PACS helped the hospital go paperless.
Thank you, Dr. Ng. And as Dr. Ng had mentioned, the transition to a hospital-based electronic medical record was really a little easier because people were used to seeing the digital images, were used to seeing the reports come through digitally to their offices. So it helped us organizationally to transition to that electronic medical record. But you know, trying to link all of the different organizations and the different systems can still be somewhat challenging, and that makes it a little bit being successful much more challenging. But we're continuing to work through those issues and are continuing to see easier and better adoption of our hospital EMR and the integration of all of the other ancillary services and other departments into that EHR.
Thank you, Linda. And as Linda says, this is an ongoing process like our RIS-PACS with both the hospital and the doctors enterprise EHR, much like all technology, which gives a good opportunity for radiologists as experts in this field to be able to insert themselves and provide value in this area. So a few words about meaningful use. Radiology experience as the first doctors to achieve MU has been, for us, an important precursor to understanding MU for the hospital. And our expertise we gained from organized medicine with connections to our state association's MU experts added much credibility to being at that table. During our stage 1 and stage 2 MU process on the radiologist physician side, there was frequent bidirectional sharing information between the radiologists and both the IPA and hospital IT teams. What knowledge we shared with them, we received in return in the other areas by these IT staffs. So this reciprocity saved us countless hours in understanding and adopting some of the more arcane core measures that we've had to encounter and navigate through, given that MU is not certainly geared towards optimizing radiology practice. Linda, would you like to explain more about the radiology MU activities and how it helped the hospital efforts to test MU?
Oh, certainly. From the hospital's perspective, the fact that our new EMR system could actually support, physician order entry and allow the physicians to accurately pick the procedure or the test that they wanted to have performed has been very beneficial. It takes out issues such as legibility of orders and making sure that we can actually determine exactly what the physician wants. And then secondly, there's a patient portal now that we are providing through our radiology RIS-PACS system that is helping to encourage our patients to utilize a patient portal. While this doesn't really impact our attestation for the hospital for meaningful use too, it's helping to bridge and educate our patients so that they're able to actually understand the value of being able to get their information and easily access that information in their electronic medical record.
Thank you, Linda. So throughout these multiple processes, whether it's meaningful use or other projects that we worked on with our stakeholders, we would like to share a few of the lessons that we've kind of learned over the years with you. In a value-based, consumer-driven healthcare world, we found that change is not only constant, it's likely accelerating. Technology alone doesn't translate into success. It takes the correct application of technology with the cultural changes to meet an organization's strategic needs. Though our natural inclination is to be plugged into the workstations, we think it's essential for any practice to devote a portion of the group's resources to engaging in Imaging 3.0 activities. California, for example, is littered with carcasses of groups who have failed to adapt, which may be more accelerated in our area because of the competition and closeness of groups to each other. Most of our big wins were built on many small steps over a period of time, sometimes years. Patience and persistence does pay off. When it comes to change of culture, we had to be willing to accept change before we could change those around us. And lastly, in whatever we try to do, we keep in mind our North Star, which is that we're here for our patients. And I wanted to end our discussion, our formal discussion tonight, with just a few words about the House of Medicine, since I've had the esteemed honor to be involved in several of those organizations. Involved in this area, from sharing meetings to understanding the macroscopic issues of I'm a radiologist, but I'm a better physician. In fact, in that work with Dr. Problem. And I thank you for the time I'm not tonight spending with us. Only a better way.
Fantastic. Thank you very much, Dr. Eng and Linda, for this terrific presentation. And now we're going to move on to the questions and discussion period. And so I'd like to encourage everybody on the line to not hesitate to enter questions into the question panel and to provide a basis for what I hope will be a nice, robust discussion with our panelists. So I'd like to start by asking a question to Dr. Eng, and would you comment on how you managed to make time to accomplish what are non-RVU generating activities while keeping up with the clinical work?
With great forethought and lots of support from the group, which we support each other. So yeah, that's a there's no easy answer for that. I wish you could have a magical elixir to say, well, you just kind of do this on the side in addition to doing your things. I think that there has to be and it comes back to what I spoke about before about changing the culture within your organization first before you can adopt changes and your value overall, but given what's going down the pike with the payment system that way, it may become an imperative to do that. And I can follow along after these have been mandated to you.
Maybe I could just press a little bit further on this issue and ask, taken on these other roles, or have you managed to maintain your clinical productivity? And if
it's a little hard for us for our group to have gauged that becoming the work. So we didn't have a pre and post where we were only productivity based. But I would say what it does require additional in committees. You are not reading out and interpreting a group has to make.
Okay. Next question. Small but mighty could be a good care group. Larger practices or institutions might actually think that you're difficult in larger and more complex settings. Do you have to offer observation?
That we have an easier time, smaller groups have an easier time in achieving.
Right. How might you suggest for colleagues who are in larger, more complex settings to take your example and apply it in there?
I would your time when easier for a larger group to be able to address them because you have more resource support, other staff support. In an acute care setting, we still have the same issues when it comes to all the kind of take the higher level that regardless of your larger group or smaller group, it's sort of building the building blocks of having experts.
I have the these activities so that they are more likely to occur.
You from hospital administration has a good manager and runs very efficiently and effective, good throughput of that. We're doing good imaging work as well. Some of the things that radiologists sometimes can get sort of bogged down as being involved in. But Chinese hospital is such a unique organization and all independent, knit, and very dedicated medical staff in San Francisco. Nearly 95% of our patients are unique patient population, and the dedication and the longevity back to the community. You see that dedication from a lot of our medical, from other members of the medical staff, that all people who are need to be part of the organization and to the community. So that helps us from an administrative perspective in making sure that we have the engagement from all of our physicians. And the radiologist, because there's a lot of families, connections between physicians, and that also helps us as well. So, we really value the radiology because they do demonstrate that dedication into our patients.
Terrific. Yeah, the question centered on how the C-suite particular rates incent these types of activities and this level of engagement.
As an organization in many ways, but there are some takeaways that I think apply to of looking to increase the success of that hospital. And given delivery going on, this is a wonderful opportunity for radiologists to get involved. I mean, if we were status quo, I think we'd have more problems in terms of breaking out of our shell or 4 rooms in a dark room of showing our value. But in a way, I look at it as a golden age of, because of the changes, there's opportunities to insert yourself to say whether it's meaningful use or dealing with the pay for performance and joint commission areas, to offer your help and say how can we make that C-suite administrator's life easier. It may take a little bit of thinking and learning about what are the important things that drives them, but that's where getting involved, whether it's going through RLI or ACR or organized medicine or just participating in these committees, will give you a better understanding of that context of radiology to all these other stakeholders, and that's the first start to be engaged. From there, I think you will start to see in your organization what things kind of bubble to the top, that people start asking you, okay, can you participate in this committee or this special task force to work on this particular problem?
Terrific. One of the themes of both of your discussions related to the centricity of the patient and providing for the needs of the patient to have them more engaged in their health care. I'm wondering, Dr. Eng, if you have any personal vignettes or circumstances that you might relate to how an individual patient encounter might have inspired and motivated you to move in this direction. Do you have any stories?
Please repeat the first part of the question regarding the individual patient.
Yeah, the question really just centers on, do you have any individual stories to relate regarding patient engagement with radiologists, and any particularly rewarding encounters that have spurred you on further to take up this cause and to make the environment more patient-friendly?
Well, I think there's a lot of different engagements that we encounter, and I think, and it's not unique to our hospital. It's just the fact of life that all doctors are really busy. We're dealing with complex disease processes. Often patients have multiple problems going on. They're seeing multiple consultants. That we as radiologists, because we cover imaging, crosses over multiple specialties, in a way are a little bit of like an imaging primary care doctor, that we could, if we choose to, be more proactive in coordinating how that workup is handled, and being a segue or a liaison for that patient. So many times when we're doing interventional procedures, which is where we actually get to see that patient, we will oftentimes talk with them and in a way assess, is this the best, not only the best procedure, but what other potential pathways should it be going through, that normally you would say that maybe the other doctors would be handling that, but because their care may not be as coordinated as they'd like to, there's that opportunity for radiologists to insert themselves and take a larger role with that. And I believe that fits in within the spirit of what our specialty is trying to do with Imaging 3.0 and others.
Dr. Rubin, if I could jump in for a second, I would
Of course.
Also add to that the fact that I think, when I look at what helps motivate us is many of our staff and our physicians actually were even born at Chinese Hospital. And so it's that strong cultural connection back to many of the family members, and our physicians have been taking care of multi-generations of families that live here in this area. And so when you see how dedicated our patients are to the hospital as well, I think that all continues to really incentivize us to make sure that we're providing the very best care that we can for them.
Yeah, that sounds like a very special and somewhat unique relationship where the community has really embraced the hospital, and where the medical staff is a part of the community of patients as well as caregivers. It's terrific. Let me turn to a slightly different topic that has come up from several of our attendees, and that relates to the nuts and bolts of achieving alignment within a radiology practice, and specifically relating to compensation models. The question was put forward, how would a radiologist on an Eat What You Kill contract do Imaging 3.0? What do you think, Dr. Ng, would be the ideal compensation plan for a practice that embraces Imaging 3.0?
Well, if I could wave a wand and be able to talk to the powers that be, the health plans, and the government that changed things, I would tell them that if you want to have fully engaged radiologists to maximize the value of what we can do in terms of the diagnostic and interventional capabilities that we do right now, that fairly reflects that it probably would have to include some sort of hybrid model where there is the traditional fee-for-service type component, but also that they have a component for more the diagnostic, the more deliberative and non-straight imaging components that we talk about here tonight, as well as Imaging 3.0 type initiatives with that. And I think they are seeing that. It just takes a while for the finance system to occur. So they're correct that we're a little bit ahead of the game if you're doing that. But I believe that if you start doing it now, you will be well positioned in the future when these things come down the road, where they will mandate that. And even before then, given competition, groups that do that will be much better positioned to succeed than those who do not.
Perhaps you might just talk a little bit, if you can, about your specific practice. How many radiologists are in the group? What is the relationship of the group to Chinese Hospital? And if you could share any details of how your group manages its internal distribution of the revenues that come in from the professional activities.
So as I said before, we have 5 radiologists involved. There's 2 full-time, 3 part-time, and our primary practice is Chinese Hospital. We do some additional work in outside facilities, but our flagship is definitely here at this hospital. What we do have is a little bit more novel compared to other groups. Is though we are small, we do have relationships with several other small and medium-sized groups in for lack of a better word, more of a federation model. So we're not part of the same group, but we share resources and ideas and information to leverage those numbers to work together on common causes, and that sort of helps the concept of you need to be a big group to be able to provide all those different services there. So we believe that size is not, given the changes in technology and our practice, that you don't have to necessarily be big to be able to accomplish and be able to meet the needs of your hospitals and your referring doctors.
Terrific. It sounds from your description that really all 5 in the group are buying in on this, and I think you described how everybody has engagement in hospital committees. How did you move in this direction? How did you get folks to buy into this change and embrace it?
Well, it's interesting. We as a group kind of had this discussion about how we operate versus other groups, and so the culture of a group, and how do you kind of get into that the whole group philosophy of being able to move together in sync, comparing what we do and comparing with other groups, whether they're bigger or smaller. And I think a lot of it comes down to partly having the right people who share your philosophy, whether it's that they already had elements of that when they come in, and or teaching them or educating them as to here's kind of the philosophy and culture of this group. Every group has their own sort of unified personality to that, and that's something that may be a little easier for a smaller group versus a larger practice, and we said that is a bigger challenge for a bigger group because your ingrained organizational structure. That's something that may have to be addressed to be sort of more malleable to be able to make those type of changes with that. So we do realize that we're at a little better advantage because we have less radiologists to be able to kind of move that culture ship.
When making culture change and this concerted decision to focus increasingly on these non-traditional activities that would generate professional reimbursement and that are more patient-focused, did you seek to identify some metrics that you can target in order to not only have the confidence internally that you're moving the bar in the right direction, but also to be able to communicate externally with the community as a whole in helping them to see what great advances you're bringing?
That's an excellent question. This is something that I think what we, as a specialty, have not done as much as we could have, but I see signs, at the national level with ACR, like the Harvey Neiman Institute, to individual groups that are starting to focus on that to say, how do you quantitate that value that's not as easy to quantitate of how many CTs you read? And what we try to do on the individual level, since lacking clear models at the moment of how to do that is to try to take on projects that may start that quantitation. So, for example, we are participating in some of the Imaging Wisely projects where we're trying to minimize preoperative chest X-rays and decrease those innocent chest rates. Now, it's not a huge amount of our practice, but what we're trying to accomplish through data collection and charting of that, and this is officially in partnership with the hospital, is to develop those system processes where they can be quantitated so that we can use that as a model to start going into like, much bigger projects, either in the hospital or with the health plan, where they're dealing with much bigger dollars, let's say with MRI type utilization, that we can show here's the pathway of how to do it appropriately, not to just cut off utilization for the sake of cut utilization, but to factor in the right amount of utilization and how to quantitate that. So that we believe is going to produce tremendous value, and some of that will be much more easier when our IT systems allow for data collection. This whole idea of big data that you sort of see in other industries, that will eventually come to healthcare, including radiology, but I've yet to sort of see our risk pack systems quite be able to adopt that and be able to have like the typical group do that just yet. Maybe the universities with their programmers can do it, but that will come eventually, and we should be prepared to be able to maximize those capabilities when they do.
Okay. Yeah, fantastic. I wonder, Dr. Eng, if you have had any experience in directly engaging with payers to help migrate the payment model away from fee-for-service. Have you participated in any care pathways in helping to establish bundles, care bundles, and that realize bundled payments that are then shared across specialties at Chinese hospital? Any experience with any of that?
We've had some. The challenge is not unique to radiology. This is something that our doctor's IPA and our health plan are actively evaluating. How do you migrate doctors away from fee-for-service, the more you do, the more you get paid, to we give you some amount of your compensation based on quality and based on working as a team-based care. And when they're solo doctors, that's not as easy. So it comes back to another example of persistence may pay off. So we have been engaging and offering our help with utilization review with their health plan, meeting with their CMO and other C-level administrators in that level to say we're here to be a resource with that. We're on committees with our IPA when it comes to pay for performance models with that. It hasn't yet come to a specific fruition as to a specific model when it comes to radiology, but we're actively engaged. We're at the table, and as they develop their overall new models, we'll be there to be able to help guide that for radiology and elsewhere in our community.
Well, clearly you and your colleagues have been very effective in engaging and building the confidence of referring physicians and other medical colleagues, to the extent that you have gained sufficient influence to be elected to be president of the San Francisco Medical Society. What a tremendous accomplishment. I wonder if you might share with our audience some of the lessons that you've learned on the pathway toward having that broader influence, and how you were able to emerge from a small group of 5 radiologists to lead what must be hundreds, if not thousands, of physicians in San Francisco.
Well, as some of you who are familiar with organized medicine or participate in organized medicine in some fashion know, we are but a small minority among all doctors in our community. And I'll have to say that part of the strategy for those of us, because we're the little mice among all the big dinosaurs in terms of numbers, whether it's surgeons or pediatricians, is a little bit of stealth mode. We come in there, and the last thing we want to do is say we're radiologists, because either they'll kind of go, who, radiologists? You know, what are you doing here? That we first prove ourselves by being active members and physicians in the big house of medicine, and then once they realize that we do have value, then we can say, okay, well, here's kind of what radiology in our specialty can do to help. And if you go back to, I'm not sure if there's the ability to go back a couple of slides to my organized medicine slide, you will see one of the diagrams where the San Francisco Medical Society actually had an entire issue on imaging 3.0, which would not come about if a radiologist was not at a higher level. And this is our way as a specialty to say, how do you provide that additional value and exposure for our specialty? Because most times we are invisible, as you may have said at the beginning of the hour, to not only our patients but oftentimes to our colleagues. And if we do want to make changes and be part of this healthcare transformation that we're now in the middle of, we've got to be there at the table with our colleagues in our own profession, and be engaged. And the worst thing we can do is sort of shut ourselves off to that and say we're just going to be holed up in our own specialty. I think that would be a disservice to our profession and disservice to our patients there.
What sorts of things are you hearing from colleagues who are not radiologists, who don't necessarily practice at Chinese hospital, that they are looking toward your leadership to help them as a community to step forward and to lead? What are some of the imperatives that are brought forward?
So you're saying for doctors who are not in my community, in terms of my
relationship
with them?
Yeah, I'm asking to the extent that you are representing the entirety of the San Francisco Medical Society. You must be hearing diverse voices coming, asking for your help, bringing ideas, asking for the society to join together, and I think it would just be interesting to hear what kind of issues are emerging.
Well, first, I suppose one of the strengths I may have coming in as a radiologist is because we interact with so many other types of specialties. We're used to engaging all different backgrounds of physicians, and organized medicine is really this melting pot of every mode of practice and specialty out there. So I felt really comfortable mixing and interacting with, a pediatrician on one side and a primary care doctor and a surgeon on another. In terms of topics, it is a little bit humorous that the subject matter is that I'm involved in my position now in the San Francisco Medical Society is not radiology specific. It's things like smokeless tobacco banning at San Francisco Giants ballpark, to e-cigarettes, to physician aid in dying. But those are all kind of general traits that, regardless of their subject, when you learn how to engage your doctors in your community and your other stakeholders, those are some of the same kind of skill sets that you allow me to be engaged and hopefully be a good leader when it comes to other non-imaging issues in organized medicine.
Super. I wonder, Dr. Eng, if you might give us a little perspective on how you view the RLI ACR leadership training and how you've engaged with it and how it has empowered your journey.
Well, my ongoing journey of trying to be a better leader and a better physician did predate RLI, but what I'm very grateful to see with the evolution of RLI is that they're filling a hole that wasn't necessarily there for our current and new generation of of radiologists coming out to learn these skills, to be able to engage your administrators, to engage other doctors, to be leaders in the community, and RLI certainly plays a critical role in that, in filling that need, and ever more now than there's ever been with the healthcare evolution with that. So they RLL and ACR, that leadership skill set and activities complements when I talk about organized medicine, whereas RLI and radiology may talk about specific skills for radiology. Organized medicine, at least for me, is a way to practice some of those things you may learn in those arenas, because there are local activities with local societies, so they do cross-pollinate each other, and I would encourage, and I've gotten a lot out of being involved in both organizations.
Terrific. We're almost at the top of the hour. I have one last question that I'd like to hear both Dr. Eng and Linda's thoughts on, and that simply is what's next? What's next in furthering this relationship at Chinese Hospital and in building even greater engagement with the community and with the patients?
I think one of the first things, and probably one of the most important things, is the fact that we are actually building a brand new hospital in the middle of Chinatown, and have really had a lot of our medical staff giving us feedback on and guidance on some of the direction of some services that they would like to have incorporated into the new hospital. And so and then the ability to connect all of that electronically, and seeing how greater digitalization, wireless technology, all those things help make us a much more efficient and effective organization. And our new hospital is slated to be completed in April of next year, and should be open by probably October of 2016.
That's very exciting. Marvelous.
Yes.
Marvelous. Dr. Eng, from your perspective, what's coming up?
Well, I agree with the immediate projects that Linda described, and then I'll also add a couple others where right now most consider us a sort of a niche type organization serving a specific community in our area. But people are always amazed how, for such a small organization, how do we compete with such large organizational structures or hospitals and so forth. So that's always the constant challenge. How do we reinvent ourselves to be relevant, to survive, if not be successful, with so many competitors around us? And that is an ongoing discussion point among the hospital leaders, the IPA doctors leaders, and the health plan leaders to work together to make that happen. And it's an exciting time for us, and we as radiologists love being part of that to sort of see and project out 20 years down the road, so that there is a Chinese hospital organization caring for our community into the future. So that is sort of the non-technical, more organizational part that we are working on currently.
Well, to Dr. Roger Eng and Linda Schumacher, I want to just express appreciation on behalf of everybody listening in today to such a great partnership that you've built, and to serving as such a marvelous exemplar of what Imaging 3.0 is all about. I also want to thank our audience for joining with us tonight for this Imaging 3.0 webinar sponsored by the Radiology Leadership Institute. As a reminder, tomorrow you'll receive an email with instructions about how to claim the RLI credit offered, and we certainly hope to see you at future RLI events. I wish everybody a very pleasant evening.